I would like to welcome everyone to our SSR Resident Education webinar on MR neurography. I want to remind everyone to sign into Poll Everywhere because we'll be using that throughout this session. It's my pleasure to introduce our speaker, Dr. Darryl Sneag. Dr. Sneag is really a world expert on this topic. He's a professor for radiology at Cornell Medical College, director of MRI research, and director of MR neurography at the Hospital for Special Surgery at New York City. His major clinical and research interests, in addition to sports and spine, is specifically MR neurography and its qualitative and quantitative interpretation. So he works closely with his physicians and consultants on traumatic brachial plexus and peripheral nerve injury at HSS. I'm so excited about this topic.
Thanks, Shivani, for the very kind introduction. It's really my pleasure to give this resident case conference, and I'd like to thank Society of Skeletal Radiology and specifically Soteris Totopoulos at NYU for the invitation to talk. So without further ado, I'm going to start the presentation. I think we're going to leave questions for the end, and I know Dr. Alawad will monitor those. But as Dr. Alawad mentioned, there's a polls everywhere integrated into the talk, so I encourage you to answer away. So I'd like to just go over a few basic concepts for MR neurography. So first, what is the hardware that I think is necessary for a successful MR neurography? And I think it's really scanning predominantly at 3T. Why 3 Tesla compared to 1.5 Tesla is because you're starting with almost double the amount of signal or signal to noise ratio at the higher field strength. This allows us to incorporate parallel imaging techniques to image faster or obtain higher spatial resolution. I also like to use a wide bore magnet for positioning a patient at isocenter. This provides more comfort for the patient, but even more importantly, homogeneous fat suppression and gradient linearity. In addition to the actual gradients, it's also important to use phased array surface coils that have multiple channels, which most of us are using on a daily basis. These smaller surface arrays, particularly when used for unilateral imaging, help maximize the SNR and subsequent spatial resolution. And we frequently combine multiple flexible coils to cover anatomical regions, particularly those that are curved around the neck, the axilla, and the ankle, for example. So when one thinks about MR neurography, or at least when I think about it as neuromuscular imaging, considering both the nerves as well as the adjacent muscles. And you can think of the muscles as your friend or friends, as guiding you, particularly when there's a more severe injury, in determining what nerve should I evaluate based on the muscle denervation pattern, understanding the innervation patterns of those muscles by each nerve. So we use a combination of T2 weighting, at least a T2 of about 60 milliseconds, but often higher, that's needed for nerve contrast relative to muscle, where the T2 is about 35 milliseconds at 3T. And fat suppression is frequently added on as well due to the long T2 of fat, which is about 200 milliseconds at 3T. Essentially, we're trying to accentuate, again, the nerves relative to the background soft tissues so we can see them, as well as to be sensitive to changes in both nerve and muscle. In terms of fat suppression, these are the most common types of fat suppression options used in musculoskeletal imaging and in MR neurography in particular. The first is chemical fat saturation. This provides very high SNR, but B0 inhomogeneity, particularly around the area of the neck, is a concern. And here we see no fat suppression. Another type of fat suppression is an adiabatic spectrally selective inversion recovery pulse. This provides more uniform homogeneity than chemical fat suppression, but it's still B0 susceptible and involves a longer scan time. And then compared to STIR, the adiabatic pulse has a higher SNR, but STIR provides much more homogeneous fat suppression. And I do use STIR for longitudinal imaging and tends to be less blurry than a Dixon sequence here on the far right, which I rely on typically for 2D imaging. So Dixon imaging or in and out of phase imaging provides homogeneous fat suppression, high SNR, but it tends to be time intensive and susceptible to motion. because you're acquiring data at two different echo times and then combining them together. So if a patient were to move during the acquisition, you may incur motion artifact. So in terms of relative fat saturation robustness, STIR being close to Dixon, this is the order. Just want to make one note in terms of vascular suppression. One technique I find helpful is to use a STIR technique, but adding on gadolinium as well. With the STIR sequence or inversion recovery pulse, I can suppress both fat as well as the vessels that are now doped with the gadolinium. So again, with a single inversion repulse, we can now visualize small but very important branch nerves off the brachial plexus. Here shown in a patient with Parsons-Turner syndrome with involvement of the suprascapular nerve. And we'll talk about this a little bit later in the talk. So the last couple of slides, I just want to get your brain thinking about nerves and muscles, kind of what features of the nerve should be evaluated, or do I evaluate on a daily basis on MR neurography? Well, first, the size, is it enlarged or not? The signal intensity, is it hyperintense? And most nerves that are pathologic are hyperintense on T2 weighted imaging. Is it in continuity, or is there focal laceration? I kind of obsess over high spatial resolution, and this is because I want to see the internal fascicular architecture of the nerve. This can tell me whether there's a neuroma, which refers to a disorganized attempt at the nerve to regenerate itself, and really has a bad prognosis for the nerve itself, or is the fascicular architecture preserved? When I look at the overall morphology, do I see constrictions as we see in Parsons-Turner syndrome? Look at the fat planes. Is there scar along the perineural fat or mass? And lastly, the course of the nerve. Does it follow its expected course, or does it deviate, or is it tethered to scar or bone, as shown on this diffusion tensor tractography image? Not something that I run on a routine basis, but just illustrates a point here of tethering of the median nerve to a prior fracture site in the forearm. Okay, and muscle features evaluated on MR neurography. When I look at the edema pattern, is it T2 bright? And in terms of the edema pattern, is it diffuse, which we see in the setting of denervation? Is it more streaky, perhaps in the setting of a muscle strain? And how intense is the edema pattern? While subjective, you can say that the image on the right here, the muscles that are involved, there's a quite intense edema pattern. Is there any fatty infiltration of the muscle to suggest that this is a chronic process? Look at the overall bulk, and for that, it's helpful to compare it to the contralateral side. And what is the distribution of the involved muscles? Are the muscles that are involved fall within a single nerve distribution, or do they suggest a more proximal lesion, maybe at the level of the lumbosacral or brachial plexus? Okay, so let's move on to the more enjoyable, hopefully, part of this talk, the cases. Okay, so here's case one. This is a 40-year-old man with sudden onset left shoulder pain preceded by 2 days of rhinorrhea and low-grade fever. And the question is, which muscles are denervated and what is the most likely chronicity? For all these cases, I've labeled what type of sequence they are. In the top left, you see a coronal T2 weighted fat suppressed sequence, and on the top right is an axial proton density sequence. I'd like you to look over the choices, think about what muscles are involved, and at what stage do you think the denervation is. So let's move on to the answer portion. And wow, we got 100% correct result. Very good. So let's go over the answer. So here I've labeled the muscles. SS is supraspinatus, IS is infraspinatus. And because we see that prominent edema pattern, the most likely scenario that this is in the acute or subacute stage. Sometimes with chronic denervation, you could still have an active component and could still be edematous, but it's not usually this bright. So that would be the best answer for this question. I'd like to show a correlate case. This is a 20-year-old woman with external rotation weakness. Here in the fluid-sensitive fat suppressed sequence on the left and the T1 weighted sequence on the right, I've labeled for you the supraspinatus and the teres minor muscle. Note that the teres minor muscle is actually quite large, and we have severe fatty infiltration of the infraspinatus muscle. So this is an example of a patient with chronically denervated muscle. And typically, if the nerve does not recover by about 6 months, sometimes a little earlier, you may start to see fatty infiltration. And this is not a good sign. This means that this is an irreversible process. I'd like to comment a little bit about denervation or make a few points. So denervation is thought to be due to axonal nerve injury, to differentiate it from just a demyelinating type injury. And the proposed mechanism of why we see that increased T2 signal intensity is thought to be due to capillary enlargement and increased permeability, as well as increased perfusion to the muscle that leads to increased extracellular water content. The earliest time one can see active denervation on MRI, at least according to the literature and rat models, is about 24 to 48 hours. In humans, this is just based on more of my anecdotal experience, about 3 to 4 days. Although I don't have a very large sample set, as you might imagine, in the first 24 hours. And on EMG, most people will wait till about 3 weeks to increase the sensitivity and the specificity of the electromyography exam, but typically one can see denervation as early as 10 days. So again, on imaging, we look for the diffuse high T2 signal, or I call it an edema pattern, with no fascial or subcutaneous fluid around the edematous muscle. And the muscle involvement will follow an individual nerve or myotomal, which refers to a root distribution. In terms of nerve injury, we use this classification. So acute refers to any time between time point 0 and 4 weeks, subacute stage 1 to 6 months, and the chronic stage more than 6 months. This is a correlated case. This is a 62-year-old woman with diffuse shoulder weakness. We have a coronal PD and a coronal inversion recovery sequence. And this case is an example of dermatomyositis. So a couple things to think about. It can be difficult sometimes if you don't have any clinical history. You don't see the nerve as to whether this is denervation or a myopathy, but some clues are to look for. In this case, is we see more fascial edema, and we see muscles involved in multiple nerve territories, suggesting that one might think that maybe you're not dealing with a primary peripheral neuropathy, but rather a primary myopathy or myositis. Okay, so we're on to case 2. This is a 35-year-old man with pain and weakness after climbing with a heavy backpack. I'm showing you on the top left the coronal fluid sensitive fat suppressed sequence, axial proton density sequence, and on the right is a MIP, or maximal intensity projection, from a 3D fluid sensitive fat suppressed sequence. The question is, from which trunk of the brachial plexus does the nerve pointed to by the blue arrow arise? And the potential answers are upper, middle, and lower. So let's go to the answer poll. And we see some back and forth. Okay. All right. So we're about 50-50, 40-60, upper, middle. No one lower. And it keeps changing. Okay. So the correct answer is the upper trunk. So the arrow is pointed to the suprascapular nerve. The brachial plexus, just to briefly go over the anatomy, arises typically from the C5 to T1 nerve roots. You can have what's called a prefixed and a postfixed plexus with relative contributions from C4 and T2, but typically we think of C5 to T1. The C5 and C6 nerve roots will combine to form the upper trunk, and one of the main branches for the upper trunk is the suprascapular nerve. So in this case, we see denervation edema pattern of the infraspinatus muscle with apparent sparing of the supraspinatus. On the proton density in the MIP sequence, we see what looks like a cystic-like structure, and this indeed is a ganglion cyst, likely arising from a labral tear, so we can call this a paralabral ganglion cyst. And the clue to matching these two up is to know where the ganglion cyst is sitting. And the ganglion cyst here is closest to the spinoglenoid notch. Therefore, we have isolated denervation of the infraspinatus with sparing of the supraspinatus. So let's go over some of that anatomy. So the suprascapular notch is demarcated by the base of the coracoid process, as shown here. So what I do when I'm reading cases to be sure I'm at the level of the suprascapular notch is I'll scroll on the axial cuts and I'll find the base again of the coracoid process, and that will tell me this is where the suprascapular notch. The branch to the supraspinatus muscle comes off just kind of at the notch or just before the notch. So if you have a ganglion cyst sitting here, you'll have denervation of both the supra and the infraspinatus muscles, where if the ganglion cyst is sitting at the level of the sphenoid-glenoid notch, as shown on the bottom images, you'll have only denervation of the infraspinatus with sparing of the supraspinatus. This is an important concept. The differential diagnosis for involvement of the supra and infraspinatus muscles, or sometimes just one or the other, would include a cervical radiculopathy. For cervical radiculopathy, one would see multiple muscles within a C5-6 root distribution involved, either multiple C5 innervated muscles or C6 innervated muscles. For example, the deltoid and biceps get contributions from both. The other differential diagnosis is Parsonage-Turner syndrome, also known as neuralgic amyotrophy. So I mentioned Parsonage-Turner syndrome a few times, and it's because it's one of my main research interests. Parsonage-Turner syndrome is considered a rare syndrome, although likely underdiagnosed, and it's characterized by severe acute pain, typically in the shoulder girdle, that lasts several weeks, and then followed by severe weakness in the distribution of one or more upper extremity peripheral nerves. Hourglass-like constrictions and nerve torsion have been reported as surgical findings during nerve exploration for the past half-century, but most as incidental findings without any preoperative imaging. Pan and others, to my knowledge, in 2011 was the first to connect these hourglass-like constrictions and Parsonage-Turner syndrome in a series of 5 patients, and multiple publications since then have described larger series, making the connection between these two entities. So these are some of the most commonly involved nerves in Parsonage-Turner syndrome. Here, the suprascapular nerve. Here, the long thoracic nerve, resulting in medial scapular winging with denervation of the serratus anterior muscle in the bottom right and constrictions of the long thoracic nerve. The anterior interosseous nerve, which I'll touch on a little bit later. Here's the axillary nerve with denervation of the deltoid. And one other nerve, the spinal accessory nerve with denervation of the trapezius muscle. Okay, let's move on to the third case. This is a 31-year-old woman with chronic neck and shoulder pain. The question is, what structure in space do the arrows and brackets respectively indicate? Again, these is the bracket, and these are the arrow pointing to this structure. So we're looking at the subclavian vein or artery, and what space are we looking at? The interscalene triangle, the costoclavicular interval, retropectoralis minor space. Let's go to the pole. Okay, so we're between the subclavian vein or artery and the interscalene triangle and costoclavicular interval. Okay, good. And we're narrowing down to the right answer now. So let's go over this. So in this case, what I'm showing you is a patient with a cervical rib here on this somewhat lordotic view and a little riblet, okay? These are structures that we look for in patients with TOS-like symptoms that may be predisposed to some type of compression or impingement on the nerves and blood vessels. And one of the intervals that my surgeons ask us to measure in both the neutral position, that is with the arm by the side, and the ABR position, or the abducted externally rotated position, is the costoclavicular interval. So costo referring to the rib, so the first rib, and the clavicle, just looking at the outer cortex. And in some articles, they've shown differences between healthy and symptomatic patients in terms of the narrowing of the costoclavicular interval, more narrowed in symptomatic patients. Forgetting the interval for a moment, though, Here on the neutral position, this is the subclavian artery, this is the subclavian vein, and the clue here you can see is that the vein is, is quite different in shape and kind of collapsible. But in the AVER position here, we see that the artery is bright, where in the neutral position, we see the expected flow void. So the AVER position, with this loss of the expected flow void, this suggests that the flow is very, very slow. And this is why the protons, if you will, are not moving out of the slice by the time that the image is acquired. Okay, so the costoclavicular interval is the correct result in the subclavian artery. Now we can further evaluate that with a contrast-enhanced scan. This is what's called a time-resolved gradient, we're called echo sequence. So we're injecting contrast and then acquiring multiple acquisitions repeatedly to get both the arterial and venous phases. And here we see in the neutral position, relatively smooth and expected contour of the subclavian arteries. But in the AVER position, we see marked narrowing and even loss of the expected contrast enhanced filling of the subclavian artery at the level of that costoclavicular space, both on the right and to a lesser degree on the left. Okay, so just a few words on thoracic outlet syndrome. This refers to compression of the brachial plexus and adjacent vascular structures that may cause pain, paresthesias, weakness, swelling, and Raynaud's phenomenon. And it may result from predisposing anatomical variations, such as a cervical rib, combined with repetitive overhead motions and exercise. The literature describes 5 entities. 1, true neurogenic TOS. That means that the electrodiagnostic study is positive, and typically the lower trunk or C8 and T1 nerve roots are involved. Next type, which is actually the most common type of image, is disputed TOS. This means that the patient espouses neurologic type symptoms, but there's no objective evidence on the electrodiagnostic testing to call it true neurogenic TOS. And then I showed you example here of an arterial type TOS. Venous TOS we typically think of with Paget-Schroeder's disease, a sudden clot in the subclavian vein, possibly in the setting of a pulmonary embolism that has then traveled, or a clot in the lower leg that has traveled, and then you can have traumatic types. Let's move on to the next case. Case 4 is an 84-year-old woman with shoulder weakness. She has a history of breast cancer following therapy. The question is, what is the most likely diagnosis? So the top left is a coronal T2-weighted fat suppressed sequence. Middle is an oblique view. This oblique view is acquired with slices perpendicular to the longitudinal axis of the nerves. So this here is the T1 nerve root, C8, C7. The way I know that is this is the first rib here. So C8 nerve root will be on top of the first rib, T1 below. And then we have a proton density image as well. The options are metastatic disease, radiation-induced plexopathy, CIDP, or neurolymphomatosis. Okay, so this is the poll. Okay, always starts 50-50, Shivani, and then people seem to narrow it down to the right answer. All right, so most of you have it correct. This is radiation-induced plexopathy. And let's go over the findings. So on the image on the top left, we see segmental thickening, hyperintensity, really mostly the supraclavicular plexus, maybe continuing a little bit further. Here we have enlarged nerve roots, again, in the supraclavicular plexus. That means the portion of the plexus above the clavicle, T1, C8, and C7. And here, this is a real, I think perhaps the biggest clue to this case is we see radiation changes of the lung, pleural parenchymal scar, and also some perineural fibrosis around the nerve roots. So the correct answer here is radiation-induced plexopathy. Let's go over a couple points. So this is the most common non-traumatic inflammatory cause of brachial plexopathy, but thankfully I still don't see a ton of cases, but that might be my bias working at an orthopedic hospital with not, we're not treating patients with radiation therapy primarily. And it's typically seen when the cumulative dose of radiation exceeds 60 gray. There's thought to be 2 phases. The acute phase, less than 6 months after radiotherapy, probably ischemic in origin, and then the chronic phase, related to fibrosis, or at least thought to be related to fibrosis. The supraclavicular plexus is most often affected. It's just due to the radiation field. And the differential diagnosis, and these were answer choices, would be direct tumoral infiltration. And again, look for that perineural fibrosis where tumor, you might see, it could be sort of nodular, but often just kind of more smoother involvement and without that perineural fibrosis. And chronic inflammatory demyelinating polyneuropathy, or CIDP, tends to be bilateral and maybe systemic as well. So this correlate case is a 57-year-old woman with progressive weakness of the left arm for 5 years. This is a MIP, or maximal intensity projection image, and this shows diffuse thickening from the roots of the terminal branches, indeed in a patient with CIDP. Unfortunately, I don't have enough time to really delve deeply into each of these topics, but I hopefully just gives you a flavor for the types of peripheral nerve cases we image on a day-to-day basis. Let's move on to case 5. This is a 26-year-old man with weakness and muscle atrophy in the hand. The question is, which nerve does the arrow point to, and what muscle is indicated by the stars? So the top left is an axial T2-weighted fat suppressed sequence, proton density, and then we have a coronal image. The answer options are ulnar or radial nerve, and then you have to pick the muscle. Is it the extensor carpi ulnaris, the anconeus epitrochlearis, or the flexor carpi ulnaris? And the answers are coming in. Good. So 100%, that means the question was right on target, or maybe a little too easy, but I'm glad everybody got it right. So let's go over the findings here. So this is an example of a patient with imaging findings suggestive of cubital tunnel syndrome or ulnar neuropathy related to compression as the ulnar nerve courses through the cubital tunnel at the level of the elbow. Again, we're pointing to the ulnar nerve here. This is hyperintense and enlarged compared to what a normal nerve should look like. And we should see no muscle, or at least this is a variant anatomy. Typically, most patients don't have a muscle in this area. And I use this term, instead of this part of the cubital tunnel, typically call this a retrocondylar sulcus. So that's another term you could use to describe the position of the ulnar nerve behind the bone, is that retrocondylar sulcus of the humerus. Okay, so let's go over some facts about cubital tunnel syndrome. This is the most common location of ulnar nerve compression. And the most common structural abnormality is the anconeus epitrochlearis muscle. However, it's been reported in 23% of asymptomatic elbows on MRI. So one may see it, and you know, more often than not, patients may have no ulnar nerve symptoms. But the idea or the thought is that it compresses the ulnar nerve against the medial epicondyle or olecranon. And treatment for cubital tunnel syndrome is typically conservative with physical therapy, sometimes bracing, or surgical transposition. Just want to go over the anatomy briefly. So we talk about the roof and the floor of the cubital tunnel. The roof of the cubital tunnel is also called Osborne's ligament. And then the floor of the cubital tunnel here is the posterior bundle of the ulnar collateral ligament. Here's the ulnar nerve within the cubital tunnel, and just a longitudinal curved MPR, multiplanar formatted image. So ulnar nerve decompression, and more commonly transposition, is often indicated for failed conservative management. Anterior transposition, there are two basic types. You can either have subcutaneous or submuscular, where it's tucked under the muscle. There's really no consensus on which type of transposition technique is best. Submuscular, I believe, is a little bit more technically challenging, but the idea is that it's protecting the nerve deep to the muscle. So here on the left, example of the subcutaneous transposition, where the nerve sitting in the subcutaneous fat, my arrow is going from proximal to distal. And then here, submuscular, proximal to distal, where it's diving deep to the pronator teres FCR mass. Okay, let's move on to case number Here we have a 22-year-old man with dull forearm pain. The question is, what nerve innervates the muscle demarcated by the asterisk? I've labeled the image for you to show you the ulna and the radius and cross section at the level of the midforearm. I've also labeled dorsal and volar, but I want hopefully all of you to realize that typically, or almost always, the forearm mass, if you look at your own forearm, is much larger than the extensor mass. So if you're looking at a forearm image, you should know that these tend to be the flexors and these tend to be the extensor compartment. So hopefully that's a few clues. So let's go to the poles. Okay, so we're being between posterior interosseous and ulnar nerve. And someone's coming in the end, the anterior interosseous nerve. All right. Okay, so this is a muscle innervated by the anterior interosseous nerve, and the muscle is the flexor pollicis longus muscle. And let's go through this. So I just want to talk a little bit about anterior interosseous nerve syndrome, where we most commonly see involvement of the anterior interosseous nerve in infected muscles. In anterior interosseous nerve syndrome, you may have one or more of the following muscles involved. You have weakness of the thumb, that is the flexor pollicis longus muscle, which I showed you, the index finger, and here's an example of somebody who's unable to closely, oppose their index finger and thumb to make what's called an OK sign or Kylo-Nevin sign, be able to pick up a coin off the table. And here's more normal apposition of, again, the thumb and the index finger with the FPL and the FDP, or flexor digitorum profundus muscle. And spontaneous involvement of these muscles and the anterior interosseous nerve is typically due to Parsons-Turner syndrome. And on imaging, what we see are intrinsic fascicular constrictions. So that means constrictions not of the entire median nerve, but of the AIN bundle of the median nerve above the elbow. This topographic map from a paper shows that the AIN bundle, this must be on a timer. The AIN bundle sits in a posteromedial position relative to the pronator teres and FCR. Therefore, I can feel fairly confident that we're looking at the AIN bundle of the median nerve. And here, denervation of the FPL. And if we look at that AIN bundle longitudinally, we see multiple, again, caliber changes compatible with intrinsic constrictions at the fascicular level. So this is to contrast with the muscle denervation within the distribution of the posterior interosseous nerve. So the posterior interosseous nerve, you can have denervation of the ECRB, or extensor carpi radialis brevis, extensor digitorum, EDM, the digiminimi, and ECU. And these muscles are innervated by, again, the posterior interosseous nerve, which will dive between the two heads of the supinator. Here's the deep, and here's the superficial head of the supinator muscle as it goes to the supinator tunnel. Technically, the posterior interosseous nerve is not the pin until it's actually left the supinator tunnel. So proximal to that, we call the deep branch radial nerve. But most commonly, this is just referred to as the pin. And I think that's all you need to know. This is the posterior interosseous nerve. Let's go to case 7. This is a 47-year-old woman with hand numbness and weakness. She had prior surgery for the same condition. The question is, what structure can be released to alleviate the pressure on this nerve? So I'm showing you 2 axial images at the level of the wrist. I've labeled for you with dorsal, and the options are the ligament of Guillon's canal, the ligament of Struthers, the adductor aponeurosis, or the transverse carpal ligament or flexor retinaculum. Let's look at the poll. Good, so the majority of you, and now 100% of you, have chosen the flexor retinaculum or the transverse carpal ligament. Let's go over this. So what we're seeing here on the fluid-sensitive, fat-suppressed sequence on the left and the proton density image on the right is a markedly enlarged median nerve as it's sitting in the carpal tunnel. I've labeled for you the flexor retinaculum. And just to contrast between what a normal nerve will look like on a fluid-sensitive fat-suppressed sequence, nerve will typically be the same signal or maybe slightly brighter than the muscle. So the real clue in this case Now, one could argue that, yes, this is bright, but really the fascicular bundles are much larger than what would be expected. Just to go over the other answer's choice, I'm not aware of any such thing as the ligament of Guillen's canal. I'm sorry, that was a bit of a trick question, but the ulnar nerve, trick answer, the ulnar nerve courses through the Guillen's canal. The ligament of Struthers, just above the elbow, but not something really to worry about. And the adductor aponeurosis is something that we think about in the context of a skier's thumb related to instability of the ulnar collateral ligament at the thumb MP joint. So a few facts about carpal tunnel syndrome. This is really a diagnosis by history, physical exam, maybe electrodiagnostics and ultrasound as well, which is to be shown to be a very useful tool to evaluate and even treat carpal tunnel syndrome. MRI is typically only obtained in the setting of a mass or residual symptoms following carpal tunnel release surgery. Just happened to catch this case, and I thought it would be a nice example to show, but I'm hardly ever asked to evaluate for carpal tunnel syndrome by MRI. A little bit of overkill, if you will. So treatment is, can be conservative, like most conditions first. Sorry. And carpal tunnel release will be performed if patient doesn't respond to conservative treatment by transecting the flexor retinaculum. However, there can be recurrent symptoms, thought maybe due to incomplete resection of the flexor retinaculum. Just one note, according to Eng et al., swelling and flattening of the median nerve may persist on MRI as long as 12 months after surgery, even in patients with good surgical outcomes. So this is an example of a patient, a cartilage case, a patient underwent carpal tunnel release, and they're asymptomatic, but we see marked scarring of the transverse carpal ligament. In my experience, this is what you'll see only in the relatively acute or subacute phase. We see that big deficit where the transverse carpal ligament will be gapping. Otherwise, over time, it'll start to scar down. And normal signal and size of the median nerve. Okay, let's move on to case 8. This is a 58-year-old man with numbness for 1 year following laceration of the right index finger. On the left, I'm showing you a sagittal proton density image, and on the top, axial proton density image, and the bottom is a T1 fat suppressed post-contrast sequence. And the question is, what's the diagnosis? Do we have a glomus tumor? Do we have a giant cell tumor of the tendon sheath? Do we have a neuroma? Or do we have a peripheral nerve sheath tumor? Let's go to the poll. Okay, so the vast majority of you got this correct, that this is a neuroma. So let's review the imaging findings. So here, the white arrow is pointing to prominent or marked enlargement of that digital nerve. It has kind of ovoid enlargement, but we do see the more proximal nerve coming into the mass and the distal nerve coming out of it, showing that this is a neuroma in continuity. I'll explain what that is in a moment. Proton density image just showing that mass-like focus. The nerve is typically the same size as the artery, the vessel just above it, which this is not. And interestingly, in this case, we don't see any enhancement of the nerve. So let's go over some of the imaging findings and kind of classifications of neuroma. So as I mentioned earlier in the talk, a neuroma is a benign disorganized proliferation of neuronal cells arising from a failed reparative attempt. And one caveat is to be careful about using the term neuroma in your report. So again, you're implying that the nerve cannot spontaneously regenerate. So if the patient does nothing, they likely will not recover unless surgery is required. So I only use the term neuroma in a report when I feel fairly confident that I'm in fact dealing with a neuroma. So these can be classified into a terminal neuroma, which is complete disruption of the endoneurium, perineurium, and epineurium, or neuroma in continuity, where the perineurium and or epineurium remain at least partially intact. And the neuroma can be partial, means only involving a portion of the nerve, or complete, the entire nerve. So what do I look for to help me decide whether I'm dealing with a neuroma or not in imaging? Well, loss of the expected fascicular architecture, and I can particularly do this with large nerves like the sciatic or the medium, median nerve. When you get to very, very small nerves, difficult. We just don't sometimes have the spatial resolution to really appreciate the fascicular architecture, or when dealing with the nerve that might be monofascicular. So the real clue is to look for focally increased size. The neuroma size will typically correlate with the native size of the injured nerve. And if the nerve size, the size is much, much larger than you expect the nerve to be, more likely than not, you're dealing with a neuroma rather than just an irritated nerve. In terms of the signal characteristics, they can be variable, and contrast enhancement can also be variable. Actually, in a paper published by Shivani and others in 2016, they evaluated the contrast patterns of neuroma. They found that in the majority of cases, the vast majority, the neuroma is enhanced, which is true in my experience, or holds in my experience as well. But some cases that may not be enhanceable, and this may be related to variable degrees of fibrosis, or maybe we're not imaging at a late enough stage following the contrast administration. So here is just an example, unfortunately, a patient who had a above the knee amputation, and this is the sciatic nerve. So this is an example of a stumped neuroma, and these can be very painful. So this is a correlate case, and I want to here emphasize the history too. The prior case, we were dealing with a patient with a laceration. Here, this patient has a finger mass, but there's been no reported prior trauma. So it looks fairly similar to the prior case on the sagittal proton density image. The post-contrast image, we see avid enhancement. So the combination of avid enhancement and no history of prior trauma, most likely we're dealing with a tumor of some sorts. Here, just to show the anatomy, the position of the digital nerve relative to the vessel. And here you can appreciate the similar size of the nerve and vessel. Here's the avid enhancement on the T1 weighted post-contrast sequence on the axil as well. Whoops, sorry. And that is an example of a peripheral nerve sheath tumor. Case 9. This is a 56-year-old man with sciatica. Question is, what are the root origins of the nerve pointed to by the blue arrow? And what muscles are indicated by the stars? Let's go to the poll. And well, we started off at 100% the right answer, and now we're pulling back, losing speed in the race. Looks like a horse race here. But the majority of you have the right answer, which is the L4 to S3 nerve root contributions, the sciatic nerve and the piriformis muscle. Okay. Now, why did I put this as a case? It's kind of a normal case. I think it's just important, to know the sciatic nerve is the largest peripheral nerve in the body. In terms of an imaging protocol, the lumbosacral plexus, it covers a big area. So you kind of want to focus sometimes in terms of what nerve or nerves are of interest. So if somebody has a question sciatica, I'll have my technologist start plotting from the top of L4, knowing that the top nerve root, the most cephalad nerve root that contributes to sciatic nerve is L4 down to S3. So knowing the root origin contributions is helpful for focusing on those root origins, and also just understanding kind of how to image. So this is a correlate case. This is a 45-year-old woman with sciatica post hamstring repair 1 year ago. I'm showing you a longitudinal or coronal image on the left, proton density, axial proton density in the middle, and a T2 fluid sensitive fat suppressed sequence on the right. And unfortunately, this is the case I see almost every single week, if not a few cases every week. This is somebody who underwent hamstring repair, but sometimes they have no repair, it's just a tear. You have a somewhat enlarged sciatic nerve, but dense perineural scar around the sciatic nerve, shown by the yellow arrow. And here is the hamstring tendon, which kind of scarred. There's some retraction, and the bracket is trying to demarcate the tethering of the sciatic nerve to the hamstring tendon. So these are inseparable. You can imagine that this might be quite painful. The nerve is not gliding properly, and it's elongated in this direction, that the patient might be symptomatic. So it's an example of a scarred tethered sciatic nerve. Let's move on to case 10. This is a 40-year-old woman with left adductor weakness following left periacetabular osteotomy. So typically for DDH, for hip dysplasia. Okay. The question is, what are the root origins of the involved nerve? So on the left, I'm showing you a fluid-sensitive fat suppressed sequence. Give you a clue, which is my arrow right here, showing denervation edema pattern of a muscle group. On the axial proton density image, I want to focus your attention to this region right here. And on the 3D maximal intensity projection, I want to focus your attention to the bright structure here as compared to the normal one on the right. So let's go to the pole. Okay, again, we started off really hot, pulling back a little bit, but the majority of you have it right, L2 to L4. So what nerve are we dealing with? Well, we have denervation edema pattern of the adductor muscles. And here is the obturator nerve. So L2 to L4 root origin contribution, similar to the femoral nerve. So the red arrows are showing entrapment of the obturator nerve at the site of some callus that formed during the periastebular osteotomy. And unfortunately, the nerve is kind of entrapped or scarred here, so it's enlarged and it's hyperintense, and we see that hyperintensity all the way upstream as well. Let's move on to case 11. This is a 27-year-old man with recent onset foot drop, and he had prior surgery for the same condition. So on the left, we're imaging the knee here, an axial proton density image, another axial PD image, but at a slightly more inferior cut. And I'm sorry, it's a little blurry, but this is a coronal fat suppressed maximal intensity projected image. The question is, what is the diagnosis? Are we dealing with a tibial nerve intraneural ganglion cyst, a common perineal intraneural ganglion cyst, a peripheral nerve sheath tumor, or a sarcoma? And here is the poll. Oh, stay, don't change your answer. No, there's probably additional people coming in, but we have 100%. Good, common perineal intraneural ganglion cyst. So let's go through the imaging findings here. I'll focus your attention first on the left image. So here's the common perineal nerve bundle. It's important to note that the deep perineal component of the common perineal nerve runs within the anterior portion of the nerve, at least at the level of the fibula. And the superficial perineal bundle you see is spared. So in this condition, which is a common perineal intraneural ganglion cyst, more commonly than not, the deep perineal component of the common perineal nerve is more affected. Here, we see this articular stalk or articular branch, both on the PD image and also on the MIP image, and it's trying to make its way to the proximal tibiofibular joint from which it's arising. I'll just make a note that the common perineal intraneural ganglion cyst, and here is a nice intraoperative image from Dr. Wolf, is much more common than the tibial nerve intraneural ganglion cyst, which can exist as well, but the common perineal is much more common. So these are mucinous cysts contained within the epineurium of peripheral nerves. They can actually have extraneural components as well. And the purported source is a degenerative synovial joint. The thought is that the synovial pressure builds up and the fluid needs to decompress. Decompresses by a capsular defect of the joint and tracks along the epineurium of the innervating articular branch, as shown here by the arrowhead. And the treatment is really surgical decompression, which involves ligation or resection of the articular branch. So if the articular branch is not resected, it's thought to predispose to recurrence. In addition to resection of the articular branch, many advocate that you also should resect that proximal tib-fib joint, at least partially, to prevent recurrence. So let's go over the relevant anatomy. Schematic is from a paper from Steve Daniels and myself and from Radiology. And just to remind you again, so the root origins are L4 to S3. Just to show the lumbosacral trunk, a bit of a misnomer, contributions from L4 and L5 that will then contribute to the sciatic nerve. Sciatic nerve will run down the leg. It will give multiple branches to the hamstrings via the tibial component of the nerve, and one branch via the common perineal component, and that's the short head biceps femoris within the mid-thigh. In the distal thigh, it'll split into a common peroneal and tibial nerve. Common peroneal and tibial nerves, although not shown here, will give us small sural branches. And then we focus on the common peroneal branch. It divides into, again, that first recurrent articular branch from which the peroneal ganglion cyst is thought to decompress, as well as the deep and superficial branches. And this just shows the innervation pattern. So tibialis anterior and the extensor digitorum longus innervated by the deep peroneal component of the common peroneal nerve, the peroneals by the superficial component, and the posterior tibialis by the tibial nerve, as well as the rest of the superficial and deep flexors. So here's a correlate case, a 36-year-old man with a palpable mass. Here are the axial proton density image. So it's a high signal intensity mass. But here, this looked a little funny. We didn't see an articular stalk, and so decided here to give contrast. And what we see here is actually the mass avidly enhances. It's not cystic, right? If a ganglion cyst, this shouldn't enhance. This is just a normal case for comparison. And this ended up being a peripheral nerve sheath tumor, not a ganglion cyst. So if you see that articular stalk, bells should be ringing. This might be an intraneural ganglion cyst. But if you don't see it, think again, consider giving contrast to look for a solid lesion. Okay, so case 12. This is a 27-year-old man with foot pain. We have an oblique coronal or coronal, oblique coronal PD, axial PD. And I have a blue arrow. I'm sorry, this is mislabeled. This would be a PD. And the question is, what structure do the arrows point to? Is it the tibial nerve? Is this the medial plantar nerve? Is this the lateral plantar nerve? Or is this the deep peroneal nerve? Let's go to the poll. Good, so the majority of you have this correct, is the medial plantar nerve. Few stragglers, the lateral plantar and tibial nerves. Let's go through this. So what we're seeing here is a ganglion cyst within the tarsal tunnel, and it's compressing the medial plantar nerve, impinging the medial plantar nerve. The lateral plantar nerve is already branched off. Now, this branching pattern is a little bit variable because you can have the tibial nerve that branches a little bit late, still running in the tarsal tunnel. But here's the medial plantar nerve. And that's why we see selective denervation here, high signal of the abductor hallucis. So this is a correlate case. This is a 41-year-old female following tarsal tunnel release 1 year prior with persistent symptoms. And here we see a lot of scar. This is scar thickening of the flexor retinaculum and the surrounding subacute tissues. And here is actually the tibial nerve really hasn't kind of branched yet. The patient had recurrent tarsal nerve tunnel syndrome, the symptoms. So while this is a commonly described entity, tarsal tunnel syndrome, I would say it's, in my experience, extremely rare to see a ganglion cyst. I only have 1 or 2 such cases. But patients will go for tarsal tunnel surgery. And then if they return with symptoms, you want to look for any scar in that region that might explain recurrent symptoms. This is our last case. 18-year-old woman with left leg pain following a glass table falling on her leg. What structures do the green arrows and the blue arrows respectively point to? Okay, so sagittal, so posterior and anterior. These are the green arrows pointing to this edge and this edge. And the blue arrows on this coronal image pointing to this edge and this edge. So let's go through the poll. Good. So the majority of you have the sural nerve. So the clue here is to show, and we'll actually just go through the next slide. I think I have the explanation. So the clue here is the labeling. We're on the lateral side. So what the tibial nerve will run medially. In the lateral aspect and posterior, you have the sural nerve that's running adjacent to the Achilles tendon. So unfortunately, the glass lacerated both the Achilles tendon, but at the same time, the sural nerve as well. So again, the clue is we're in the lateral region of the distal lower leg, just above the ankle. So the sural nerve is a pure sensory nerve. Again, innervates the lateral ankle and foot, the level of the 5th metatarsal base. I briefly mentioned the anatomy. Symptoms are pain and paresthesias along the lateral ankle and foot. And it's important to know it's a frequent target for biopsies and nerve grafting due to its superficial location. So I'd like to really thank you for your attention. In summary, I believe MR neurography is an underutilized but highly valuable technique. Optimized hardware and software, including 3T, flexible high channel receive coils, combination of T2 weighting, fat suppression, and sometimes vascular suppression are required for a successful exam. And familiarity with anatomy, both the nerve and the muscle, and paying particular attention to the clinical history can help point to the correct diagnosis. So thank you very much for your attention, and I'll turn it over to Dr. Alawat now, Shivani, to entertain any questions or comments.
Thank you so much, Darryl. You know, when I was a resident, we were only talking about extrinsic compression of nerves and denervation patterns. So this is amazing that the residents have an opportunity to see primary nerve findings. I've been looking at the chat box pretty compulsively, and I don't see any questions. So I'll just pose one for you. Can you give the residents a tip on how to decide that the nerve is normal?
So the biggest tip is just to look at nerves on every single MRI you pull up on. Okay, I mean, I think this is true of all anatomy. You know, I encourage our residents and fellows on every plane to be able to name every muscle, to be able to try to identify every structure. I mean, as you know, Shivani, you know, as musculoskeletal imagers, probably like, you know, neuroradiology, maybe other disciplines within radiology, the anatomy is really critical. And I feel like almost the pathology comes secondary. So just look at every, you know, nerve or as many nerves as you can see on cases, and that will help you familiarize yourself for what a nerve, you know, a normal nerve looks like versus an abnormal nerve. And then how do you know what you're seeing is normal, abnormal? Well, look at the clinical history, the symptoms. I've learned a lot by my colleagues by looking at their electrodiagnostic exams, by their EMGs. So if they're finding denervation of muscle, I want to make sure that I can find it on the MRI as well, you know, at least if it's severe denervation.
We do have two questions. So the first is, what is your typical brachial plexus protocol? What exact sequences do you use?
Sure. So great question. So basic protocol, I start off like any, you know, protocol with a localizer, and then I like to get an axial stack. I like to have one different type of contrast. So I usually get a proton density contrast. I do unilateral imaging because I try to optimize the spatial resolution. In rare circumstances, I'll get bilateral imaging for comparison, but usually unilateral imaging. After the axial proton density sequence, I get a coronal T2 weighted fat suppressed sequence. I have that run all the way anterior to posterior. And the purpose of that is just to see if there's any muscles that are denervated within the field of view or any big abnormalities. After that, I get two stacks of oblique sagittal fluid sensitive fat suppressed sequences, both proximal and then distal to the level of the coracoid process. The proximal stack is done without respiratory gating. The next stack is done with respiratory triggering or gating. I put a bellows around. So we do prospective gating because I found that it can be helpful to mitigate against the motion artifact. And then more recently, as part of a routine protocol, I also do add in a 3D stir sequence and kind of oblique just to cover the nerves to be able to get much thinner slices.
So there was another question about who interprets neurography. Is it neuroradiology or MSK?
Yeah, that's a great question. So often when I lecture, I call MR neurography no man's land because it's kind of fallen between the two disciplines historically, between neuroradiologists and musculoskeletal radiologists. I would say it depends on the training, both of the musculoskeletal radiologists and neuroradiologists. Certainly, I think as musculoskeletal radiologists, we're probably much more familiar with the more peripheral anatomy, whereas the neuroradiologists who do a lot of MR neurography, you know, they'll focus predominantly on the brachial plexus and the lumbosacral plexus. But, you know, if they're interested and curious and motivated, they'll end up learning the peripheral anatomy, and neuroradiologists can do it as well.
Yeah, in our practice, it's MSK radiologists, even brachial plexus.
Okay.
Another person had a question about target sign. How often do you see it in a nerve sheath tumor?
I don't know the number off the top of my head, but I know the literature, you know, it's not specific for differentiating, you know, say the schwannoma versus the neurofibroma. Shivani, maybe I'll turn the question. I think you're the real expert on nerve tumors. Maybe
We
let
see
you answer.
about more than half, about 2/3, but not all of them. All of them don't. So you look for continuity with the parent nerve, smooth margins, hopefully a target sign. And more often than not, you will not have denervation associated with a nerve sheath tumor, while if you're thinking a neuromine continuity will typically have denervation associated with it.
Right.
People had additional questions about how often to use DTI. I think that we're somewhat out of time. We're a little bit over actually. And it may be beyond, do you use DTI? You can just answer quickly and then we'll
Just
be done.
briefly, I consider it a research tool. So I don't use it routinely, but I do use it a lot, but for research purposes, predominantly DTI, that is. I think diffusion weighted imaging, or DWI, can be helpful, particularly in doing tumor work, determining whether things are more aggressive perhaps than others, or solid. But diffusion tensor imaging, I think we're just limited by spatial resolution currently to really properly evaluate peripheral nerves. A more, perhaps a more robust target, given the larger fiber diameter size, would be the muscle. So that's what I'm currently exploring, is actually looking at diffusion tensor imaging to evaluate muscle denervation.
All right, well, thank you so much, Darryl. Thank you everyone for participating and having these great questions. I just want to tell you about the next session, which will be on musculoskeletal artificial intelligence. So
Wow.
hopefully you can join then too.
Okay.
Thank you.